Thanks for joining us tonight. I'm Fahim Sandhu from Georgetown University. I'm joined with several of my colleagues here from Georgetown, Dr. Jean-Marc Voyadzis, who's director of our spine oncology program, and then two of our senior residents, Dr. Gnel Pivazyan and Dr. Kelsey Coburn, who will be helping present cases tonight. And we chose to present interesting spine oncology cases because these present many different challenges. We've chosen some cases that represent kind of bread and butter metastatic tumors, as well as complex metastatic tumors requiring some real biomechanical stabilization and considerations, as well as challenging intradural, intramedullary pathologies that have some nuances regarding the use of microsurgical techniques, ultrasound, and intraoperative neuro monitoring. So with that brief introduction, I think we can get started. And Gnel, if you wouldn't mind, starting with the first case.
Okay, thank you. All right. Okay, so the first case is a cervical thoracic pathologic fracture that was reconstructed. So I'll present that. This is a 57-year-old female with known lung adenocarcinoma who was referred to the ER for 3 weeks of mid-scapular back pain, left arm pain, and lower extremity weakness. She was ambulatory at the time of presentation, but with increasing difficulty. Her past medical history was significant for DVT. She was on Eliquis. She had multiple lung lesions with prior history of malignant pericardial effusion. On exam, as far as her motor strength, she's 2 out of 5 in her left interosseous muscles, otherwise full strength. She is hyperreflexic throughout her lower extremities. On the left side of the screen, the mid-sidal CT of the cervical spine demonstrates primarily C7 and T1 vertebral body pathologic fractures, as indicated by the white arrows. The left parietal CT in the middle of the screen and the axial CT of the cervical spine demonstrates fractured C6, C7 facet on the left side. Additional lytic lesions were noted on the vertebral bodies of C6, T2, T3, as indicated by the yellow arrows. Thoracolumbar CT shown here redemonstrates a kyphotic deformity at the cervicothoracic junction caused by the pathologic fractures. Oncology was consulted, and they deemed that given the young age, good functional status, and disease burden, the patient is a candidate for further systemic treatment and has at least 6 to 12 months of life expectancy. Unfortunately, pre-op MRI was not available. As far as a stability assessment, the lesion is junctional, involves mechanical pain. It's a lytic lesion causing deformity with greater than 50% vertebral body collapse, and involves unilateral, posterolateral elements, giving a total sin score of 14, which is in the unstable category. So in summary, a 57-year-old female with lung cancer presents with myelopathy, left hand weakness, C7, T1 unstable fractures with junctional kyphosis, and is a candidate for systemic therapy. At this point, she was deemed to be candidate for surgical treatment. In particular, the goals of surgery were stabilization of the spine, realignment of the kyphosis, decompression of the spinal cord, and exploration of C8 or T1 nerve roots. So before moving forward, I'll stop here in case there's any comments from the panel on the goals of the treatment and the treatment strategy, and I'll let Dr. Sandhu discuss the nuances of the surgery.
Was a pre-op MRI done and we're just not available or not done for some reason?
It was done at the outside hospital. Unfortunately, was not available. I try to bring it up, but
got it.
Able to.
Yeah, can you just, this is Izzy, can you just repeat the neurological exam again? Was it just isolated hand weakness?
She was subjectively weak in lower extremities as far as her complaints, but she was also myelopathic. She was hyperreflexic in lower extremities and having difficulty with ambulation.
Yeah, and there was tumor burden in the neural foramen on the left side at C7T1, contributing to the left-hand weakness. So she was only 2 out of 5 in the left-hand interosseous muscles.
Fair enough.
Yeah, this obviously is an unstable situation that requires both anterior and posterior stabilization. We wanted to decompress the spinal cord and help with the realignment with the anterior approach, and plan to perform corpectomies at C6, C7, and T1, and then stabilize it with expandable cage and integrated plate. And then stage 2 would be a posterior approach with C2 to T5 stabilization, laminectomies, facetectomy at C7, T1 to decompress the nerve roots, and then provide posterior stabilization. And and prior to surgery, to help with alignment, the patient was placed into Gardner-Wells tongs the day before surgery with 20 pounds of traction. And you can see this helped significantly improve the alignment and restore some lordosis prior to surgical intervention.
What was the lytic lesion like in T2, since that's going to be the bottom of your construct?
No, we extended it to T5. The construct goes down to T5, but there was involvement of tumor in T2. You can see there's some lytic lesion. It was only partially involving the vertebral body, and so I did place screws there and augmented the vertebral body with cement as part of the construct, so those screws would be more stable. But I didn't feel like we needed to take that vertebral body given the only partial involvement of the vertebral body. So you can see after the anterior decompression and reconstruction, we have reasonable lordosis and decompression, and then we stage the posterior surgery from C2 to T5. And consideration here is that we're crossing the cervico-thoracic junction. You don't have good points of fixation at the junction because of the involvement of tumor. So C7, T1 screws were not placed because of tumor involvement and the need to resect those vertebral bodies as part of the surgery. And so using a 4-rod construct was very beneficial in providing some additional stability across that cervicothoracic junction, and then reinforcing that T2 level with cement to stabilize that as well. You can see a good decompression as well as realignment of the spine following the surgery. And there were no postoperative complications. The patient was discharged home a week after surgery, and at 2 months was ambulatory with significant improvement in pain, at which time she had already started chemotherapy and radiation.
Hey, Fahim, can you go back to the previous slide showing the CT?
Sure.
Were you concerned about the bottom of the construct? Because it looks like it's not very, it almost looks like it's perched on, I don't know which level that is, T2 or T3.
Yes, we were, it's hard.
Or did that get displaced, over time?
No, this was an immediate post-op. So yeah, it wasn't perfect at the bottom. I mean, I was a little concerned about that, but I felt we had very good posterior stabilization, and it was more than 50% still on the vertebral body, and would serve as an adequate construct anteriorly. So it was not revised or changed based on that.
Fahim, I can't think of any other scenario in what we do that's more difficult than tackling the anterior and posterior areas of the cervical thoracic junction for whatever pathology. But one of the things that I have most recently resorted to is going with a posterior approach first. And I find that has really helped me when I'm doing a case like this, because I can get the alignment, I can get the stability, then I don't have to worry about forcing the weak bones above and below to try to get correction. And then when I go from in front, it actually makes it a lot easier because all we're doing is filling a gap. So we just do the carpentry and slot something in at that point in time. And just for consideration, I know traditional techniques, decompress from front, then stabilize from behind. But I've really found it beneficial to do the posterior first on these and then come back in the front, especially at the cervical thoracic junction.
No, that's a great point, Izzy. And I think there are many reasons why that would be beneficial. I think, in a case like this, sometimes, in the heat of the moment, we kind of get pushed by the spinal cord compression anteriorly. And, I chose to approach it that way. But I think coming from behind is certainly a great way of doing it, establishing the alignment, and then taking care of the anterior part second. No right answer.
I think that's the age-old question: is do you go anterior first or posterior first when you've got severe cord compression? I think if there's ventral cord compression, typically, I think most would want to consider an anterior approach. But I think the posterior approach is a great one because it affords one the luxury of a very wide decompression from a multi-level laminectomy, but with the added risk of positioning prone, which is a greater risk than going straight anterior. So I think it's that age-old question is, do you go anterior, posterior? And it seems like both approaches would be very reasonable here in terms of the chronology of it. Fahim, do you think that cage and plate construct could have increased the risk of it backing out? I personally don't I like to do expandable cages and then a plate and construct separately, because I think the rigidity of these cages have a tendency to back out, or a greater tendency to back out as a unit than if you put an expandable cage alone and then a plate as a second stage.
Well, we don't personally like these cages for any other indication than large constructs to fill the gap, and tumor cases or the ones or infection where you have to do multi-level corpectomies. And it's nice to have an expandable cage in that situation, just because of the distance that you have to span and getting good contact at both endpoints, and then plating it is already kind of lined up for you. But I agree, there are some issues, and I think they are more rigid. It's more difficult to kind of visually confirm the final orientation of the plate, especially in a long construct at the base. When you're down at like T1 or T2, that can be a challenge. So you just have to be aware of the limitations of each kind of cage that you use. But I do find it helpful when you're trying to span a long distance to have an expandable cage to kind of safely fill that defect.
Fahim, a couple of technical questions. Number one, any issues with the anterior exposure getting down to T2, number one? And then number two, posteriorly, did you use any advanced navigation or robotic techniques for your construct? And if you did, specifically, which system did you use?
Thanks, Scott. Fortunately, she had a thin neck, and getting down to T1 was not too difficult. It's always a little bit of a challenge, though, visualizing that. So you have to do a wide dissection. Whether you choose to do a transverse incision or a more standard carotid incision, I think that's surgeon preference. But a transverse incision will get you there. You just have to center it properly over the kind of the middle point of the the exposed area that you desire to expose, and then just do a wide dissection to really gain that access, and then use the handhelds when necessary to really visualize the top and the bottom. And then posteriorly, we did not use any robot in the situation, but did use intraoperative navigation with Aero and BrainLab, which is very helpful for placing these thoracic screws and C2 as well.
Fahim, how long did each of the procedures take, the front and then the back individually?
Probably, I think about 3 hours for the front and probably about the same for the back. Maybe a little over 3 hours on the back.
Yeah, I think the quad rod construct here was very helpful, particularly because of the extent of disease for this lady at the cervical thoracic junction. I will say that our radiation oncology colleagues will sort of grimace at this because it does make the efficacy of radiation treatment as an adjuvant treatment modality a little more challenging for them, and it does, I think, make the planning for radiation a little more challenging for them as well. Would anybody consider the use of carbon fiber or PEEK cages here as a sort of spinal oncology case to improve or to facilitate postoperative radiation treatment and planning?
I have not seen a posterior cervical carbon fiber system. Is there one out there?
No, I think they're really advertised for thoracolumbar.
Yeah, that's what they are. And I've used them on a couple of cases. And the big benefits, obviously, the post-op imaging and then the potential for radiotherapy. The drawback of the carbon fiber constructs that are out there is because it's carbon fiber, the tulip heads have to be really, really big to get the biomechanical stability that you want. And the rods are pre-contoured, pre-shaped, which makes life very difficult for you. So the technology is developing. It will be better. It is a good idea, but I haven't seen anything in the cervical spine yet. So I was intrigued that you may ask that.
Yeah, I haven't seen it either, and I agree completely. I think that you can't contour the rods; they're pre-cut, they're very rigid, and I think the constructs are probably more likely to fail. And I think they're maybe designed for spinal oncology cases where folks are going to have 6 months to a year to live. But there's so many great advances in cancer care now that I'm not sure that that it's worth considering them unless you're considering proton therapy for rare cases like chordomas and cetera.
Yeah, I've moved my treatment philosophy away from survival. I assume everyone's going to survive because the oncologist keep surprising me. I've got lung mets, renal mets that are 5-7 years out now, 10 years out, a couple that I've been seeing in follow-up that have been just remarkable recoveries.
Thanks. So Gnel is going to give us a brief biomechanics talk on some of the research he's done with Brian Cunningham in his lab at Union Memorial Hospital on the quad rod constructs and comparing them to standard 2-rod constructs at the cervicothoracic junction.
Okay, thanks. So yeah, this portion is of the presentation is about biomechanics study of 2-rod versus 4-rod reconstruction of the cervicothoracic spine. This study hasn't been published, but has been presented at the AANS meeting last April in Los Angeles. I want to give a shout out to the principal investigator of this study, Dr. Brian Cunningham. He's the director of Musculoskeletal Education and Research Institute at MedStar Union Memorial Hospital, Department of Orthopedics. So deciding on the most appropriate hardware for fixing cervicothoracic junction can be challenging. In such cases, junctional pathologic fractures like the one we just presented, or cervicothoracic deformity requiring extensive correction in multiple planes, PJK, DJK, extension of constructs, etc. And cervical and thoracic spine differ not only in physiology in terms of alignment and mobility, but also in hardware designs. For instance, cervical spine typically is instrumented with lateral mass screws, which accommodate smaller diameter rods. compared to the thoracic spine pedicle screws, which can accommodate greater diameter rods. So therefore, choosing the most optimal diameter, material of the rod, configuration can be challenging. So some of the complications that can be caused by inappropriate instrumentation is, for instance, excessive motion that can lead to pseudoarthrosis, or excessive rod strain that can ultimately result in rod fracture. So therefore, this study sought out to evaluate the range of motion and rod strain using different rod diameters, material, and reconstruction types. So cadaveric cervical thoracic specimens were instrumented from C3 to T4 and were destabilized by performing laminectomies, medial fasciectomies from C4 to T3. This illustration that was kindly provided by Anna Buford demonstrates 5 reconstructions that were tested in the experiment. From left to right, A, B, C, D, and E are 3.5 millimeter titanium 2 rods, 3.5 millimeter titanium 4 rods, taper rods made of titanium, 3.5 millimeter to 5.5 millimeter. And then the last 2 are 4 millimeter cobalt chrome 2 and 4 rods, respectively. So on the left side, you're seeing a gimbal apparatus performing flexibility testing, the intact specimen, FlexX, lateral bending, axial rotation. The video is at 20x speed. And then here on the right side, you are seeing rod strain measurement as a specimen subjected to extensions and flexion. The screen in the background demonstrates a strain change from negative number to positive number. All right, and as far as the results, this figure demonstrates a range of motion of the reconstruction groups in flexion, extension, lateral bending, and axial rotation, marked in 3 shades of gray. The columns represent each of the 5 reconstructions, and the findings were intuitive. Overall, cobalt chrome rods, represented by the rightmost 2 columns, had smaller range of motion or greater stability than titanium 2 or 4 rods, as represented by the leftmost 2 columns. If you look at the middle and right section of the graph, which represent the lateral bending and axial rotation, addition of an accessory rod to a titanium 2 rods reduced the range of motion. The cobalt chrome 4 rods were more stable than 2 rods. This difference wasn't as pronounced. And then lastly, the tapered titanium rods, represented by the middle columns, demonstrated superior stability compared to both titanium 2 or 4 rods, represented by the 2 leftmost columns. So to summarize this figure, the order of rods in increasing stability was titanium 2 rods, titanium 4 rods, titanium taper rods, cobalt chrome 2 and 4 rods. And then this figure demonstrates the strain at the cervicothoracic junction for all 5 reconstructions, as well as the accessory rods in flexion and extension. The main takeaway messages here are that 1, strain was not significantly different between 4 versus 2 rods. And most importantly, that tapered rods, interestingly, had the greatest strain, despite having a great range of motion reduction. So, in summary, the addition of accessory rods to a traditional 2 rods improves the biomechanical stability of the construct. Titanium taper rods provide equivalent stability compared to cobalt chrome, but at a cost of much greater strain, which puts the taper rods at greater risk for failure. All right, and that's all of it.
Great, thanks, Gnel. And then why don't we move on to case number 2, Dr. Boyantz's case. I think, is Kelsey going to present this, or are you?
I'll present this, and then the last 2 she can present.
All right.
This is a 15-year-old boy with progressive occipital headaches, nuchal rigidity, nausea, vomiting over the past month. CT head was negative. They did an LP at the outside hospital that reportedly the pressure was elevated. She developed transient post-procedure 6 nerve palsy, which resolved. He had progressive neck pain, arm and hand numbness with gait instability, and an exam was myelopathic, was with diffuse motor weakness. Here's the imaging demonstrating a intradural intramedullary lesion at C6 that is off-center to the right side and particularly located ventrally.
Just a correction, Gnel, this is intradural extramedullary, right? It's originating from outside the spinal cord.
Yeah, thanks. All right, and I'll leave it here and open the mic for any suggestions for approach.
Yeah, this is a tough one in a 15-year-old adolescent with profound cervical myelopathy. There are two basic approaches to this: the anterior approach, and that would necessitate a corpectomy, single level at least, or maybe a 2-level, which is pretty extensive for an adolescent. The advantage, I think, anteriorly is you have direct exposure to the tumor, but you have late exposure to the spinal cord, which is severely compressed dorsally. The posterior approach, I think, confers additional advantages in that you do have broad exposure to and immediate exposure to the spinal cord, but hard to say what you're going to find in terms of the ability to rotate the cord and the ability to get around the tumor, and you might have to debulk the tumor internally and not sort of remove it and block if at all possible. The posterior approach, I think you would probably avoid any instrumentation, which is a distinct advantage for this adolescent. So I think there's several ways of approaching this.
For those of us that don't see this a lot, obviously you know what it is, but before you did, going in, what was kind of the differential of the pathology?
Gnel, you want to comment on the possibilities?
Yeah, intradural extramedullary, something like your more common ones: meningioma, schwannoma, neurofibroma, those being by far the more common pathologies.
Yeah, that was certainly what we were thinking going in. Of course, the intraoperative findings can be a little different, and how mobile that tumor will be, you can only determine once you expose it.
Jean-Marc, this was kind of an unusual presentation clinically with headaches, nausea, vomiting. Do you think that was a red herring, or did the tumor affect CSF circulation, some transient hydrocephalus? What do you think?
Yeah, I think it definitely obstructed cerebral spinal fluid flow, and I think it caused, without a doubt, I think maybe some transient intracranial hypotension, stretching of the abducens nerve, and an abducens nerve palsy. So I think that certainly was related to this, with significant limitation of CSF flow around the cord.
Is there a rationale for just doing a posterior decompression initially before your anterior definitive surgery, not planning on working around the cord and trying to debulk the tumor, but just to decompress the canal a bit, like we would do in a spondylotic myelopathy sometimes, where you want to give the cord a little bit of room so that you don't cause or hopefully decrease the risk of injury anteriorly?
I think so. That'd be very reasonable. And, I think if you're going to consider just a decompression, might as well, expose and explore intradurally to see if you could potentially resect it posteriorly. And I think a posterior approach is very reasonable here as well, with the biggest advantage being avoiding hardware in this adolescent, probably not without a need to stabilize, and you have exposure of the cord immediately. My concern, the reason I went anterior, is I just didn't know how mobile the tumor was going to be. I didn't know if it was firmly adherent to the ventral surface of the spinal cord and the potential risk of vascular injury of the spinal cord without seeing it from a posterior approach. I didn't know how much, whether or not it was adherent to the nerve roots here, would be C7, C8. And so I thought that even though we would have to instrument and stabilize this adolescent, I felt that an anterior approach was best, because you'd be able to immediately expose the tumor and then see if it's mobile, and you can remove it and dissect it away from the cord.
Yeah, I think you make a good point about the visualization of the ventral surface of the spinal cord, because, at first glance, it seems like you have a pretty reasonable corridor on the right side of the canal posteriorly to take it out. But it really is an unknown how that tumor will behave, and whether it's stuck to the ventral surface. And you could really hurt the cord if you work in a blind manner, trying to resect some of that tumor ventrally. So, yeah, I think that's a very sound reason for coming anteriorly.
We were pretty fortunate because after the intradural exposure, it was actually quite mobile, and it behaved as a schwannoma. It was a little different than a schwannoma. It was a pretty rare granular cell tumor, which is of neural origin, but they can develop in other tissues of the body. It's a pretty rare case of an extra medullary intradural tumor, and it appeared to be originating from the C8 nerve root, which we could dissect the tumor away from without consequence. So we were fortunate with this in that it was pretty mobile. We were able to dissect it out just by doing a single-level corpectomy, not having to do a two-level corpectomy and stabilization, and he recovered well from this.
All right.
Can you
That's
go
a
back to the
spectacular
intraocular picture?
case.
Now on C, I'm sorry, on C, are we looking at the tumor? Or are we looking at the cord?
C is the tumor. It's the tumor resection.
Huh.
Yeah, the cord is behind it. You can see a hint of the
Amazing.
cord in picture B.
Yeah, you see it in the corner, the right-hand corner.
Right.
Yeah.
And how long does it take for the cord to re-expand after being so compressed?
I can't recall. We did this a few years ago now, but I think we got an MRI immediately post-op. I think this one was at 1 year, but it re-expands pretty quickly. Yeah, and thankfully that he recovered neurologically completely. He's an Amish boy who went back to his farm, and he couldn't work in his parents' home doing handiwork for a long time. He just got weaker and weaker, and eventually presented in the emergency room at a really late stage.
That's a great result.
Beautiful decompression.
Very good. Kelsey, do you want to start with the next case?
Yeah, absolutely. So our third case is a young woman with an intramedullary tumor in the cervical spine. So she's a 21-year-old healthy female nursing student who presented to RED with acute onset of numbness and tingling in her hands and feet, which actually came on while she was on a nursing school shift. On exam, she was full strength, no motor deficits, but she was diffusely hyperreflexic. And on her sensation exam, she had decreased sensation on the palmar surface of the hands, and then from below the knee to the feet on both legs. So at the outside ED where she presented, they started with a dry head CT, which you're seeing here. So on the left, you see two axial slices, and on the right, a sagittal slice, and you can see this dilation and expansion centrally in the lower brainstem and the cervical cord, concerning for a syrinx or a cystic mass. So that prompted her to be transferred to us, where we did an MRI with and without contrast. These are the pre-contrast images. On the far left, we have the T1, and then the T2, and then an axial. So you can see on the sagittals that you have this large intradural intramedullary mass spanning from about C4 to C7, and then a large surrounding syrinx, which goes essentially from Obex to T11. Can you go to the next? Yeah. These are the post-contrast images. You can see it has a sort of an infiltrative pattern and is heterogeneously enhancing. So treatment considerations for her, goals of surgery, we did not at this point have a tissue diagnosis for her. Depending on the pathology, resection could potentially be curative. And then we wanted to consider, a laminoplasty versus a laminectomy. And if we could avoid having to do a fusion, we would try to do that. And then neuromonitoring was obviously a important consideration for a case like this, so high risk. And just a note on that neuromonitoring, we used D-wave monitoring as well as dorsal column mapping with a bipolar electrode in order to help find the midline for the myelotomy, which can be significantly distorted in cases like these. So Dr. Sandhu, any thing to add about the considerations before we go on to the surgical treatment?
We use those. I think intraoperative monitoring is essential in cases like this, and really will guide the resection and tell a surgeon when to stop and when to pause and then move on. But in addition to the D-wave mapping and the dorsal column mapping, we use standard motor evoked potentials and sensory evoked potentials, somatosensory potentials.
We have a brief video from the microscope.
Yeah, this is just a couple minutes to kind of go through the major steps of opening the dura, tenting it. We used intraoperative ultrasound to make sure we're localized over the tumor. That's very helpful as well. You can really get a good view of the tumor parenchyma with the ultrasound, both before and after opening the dura. This is the dorsal column mapping, so we have a good idea where to make the midline myelotomy, and then just start in the midpoint, and then work toward both ends of the tumor. And I think in a case like this, having a syrinx is very helpful because it kind of defines the limits of the tumor. So we work toward the two ends, and then carefully start defining the margins between the normal spinal cord parenchyma and the tumor itself. And then because it was so large, can work on debulking it using an ultrasonic aspirator. This is the D-wave electrode being placed in the subdural space. This is following resection. During this case, we had a drop in the D-waves at one point while we were resecting the right side of the tumor, and we stopped and finally closing the dura. But as most of you know, you can have a complete loss of the motor evoked potentials, but maintenance of D-waves, and still have a good functional outcome from a resection like this. It's much more reliable in terms of mapping the corticospinal tracts with the D-wave, and has been correlated better with long-term outcomes. This was the post-operative MRI scan showing gross total resection. Fortunately, she had good strength. She had some weakness, some ataxia immediately after surgery on the right side, predominantly where we had that change in the D-waves. We left a lumbar drain to help with spinal cord perfusion for 5 days. And then at 14 days, she was discharged home, to rehab, and spent a couple weeks there before going home. And for her sake, I really thought this was going to be an ependymoma based on the imaging, but it turned out to be a grade 1 astrocytoma, which requires no further adjuvant therapy of radiation or chemotherapy. And at 1.5 years, she's doing very well. The only weakness she has now is some trace right tricep weakness. She has residual hyperreflexia, but she's working full-time as a nurse, and otherwise living a very normal life. And you can see, again, resolution of the syrinx, as well as no recurrent tumor at 1.5 years.
So Fahim, what is the likelihood of recurrence of this astrocytoma?
It's low. This was a grade 1, and since we really got a good resection, the likelihood of recurrence is very, very low.
Good for her. Superb.
Fahim, when you were doing the dissection, I noticed you weren't cutting anything. Just sort of looked like you were dissecting with a very small freer, the midline. Is that right?
Yes, I think this is a case where having an excellent assistant, having 4 hands that can really make a difference, and someone helping retract the edges, but then the main surgeon kind of working on the margins and really trying to carefully separate the planes, and at some point using just pledgets of gel foam to separate normal parenchyma from tumor is helpful. And here, we're just carefully peeling what looks like clearly tumor from spinal cord parenchyma. And then where it wasn't clear, you have to be much more careful. Where we're in the bulk of the tumor, using the ultrasonic aspirator to help really get the meat of this tumor out, because it's quite large, and it's hard to just pick away at it. You can actually injure the cord if you put too much traction. So, using the ultrasonic aspirator is very helpful. And then really paying attention to the intraoperative neuromonitoring to guide, when you're being too aggressive or maybe violated the margins of the tumor spinal cord parenchyma interface. And you can see at some point, there's good margins on the poles of this tumor, but as we work toward the ventral base, especially on the right side, I kind of lost the margin, and it just kind of blended into the tumor or to the spinal cord parenchyma. So you have to be very mindful of that as you're dissecting.
And that's a great result. That you mentioned you lost both your motor evoked potentials and the D wave. Both?
No, the D waves were decreased. And to be honest, I don't remember whether we completely lost the motors or not. I don't think we completely lost them, but in general, if the D waves drop by less than 50%, that is still correlated with good functional outcome. If it's less than 50%, then you should really consider stopping the resection, and or at least temporarily, and then seeing if you can get D waves back before proceeding. But if it's persistent, then you may want to limit the extent of resection. If the D waves are gone, that's an indicator that there's probably a significant injury to the corticospinal tracts, and there will probably be the result in postoperative paraparesis or paraplegia.
Yeah, I found for these cases that the D wave monitoring, so intradural distal monitoring, is almost an essential adjunct to intramedullary tumor resections. It's been shown, there's a group in Italy that's published on this, that it has positive predictive value, as you said, in terms of predicting a neurologic deficit. And if your D wave potentials still exist while your MEPs go down, in general, you should be able to continue with your tumor resection.
Yeah, no, I agree. I think you cannot do resection of a intramedullary spinal cord tumor without mapping D waves. So obviously, you can't use it in very distal tumors, less below T10, because there are no corticospinal tracts to monitor below that. But anything cervical down to T10, I think D waves are essential.
Okay, I think we'll move on to the next and last case, which is a case of a lumbar pathologic fracture. This one is Dr. Voyatzis's. So this patient is a 38-year-old female with a past medical history of widespread metastatic breast cancer, who was sent to the ED from radiation oncology clinic due to a finding on her lumbar MRI from that day. She had been complaining of worsening left lower extremity weakness and numbness, primarily in the L3-4 distribution, and persistent mechanical back pain, which is what prompted the repeat MRI. On exam, she had mild proximal weakness, 4 out of 5, and then decreased sensation in the L3 distribution on the left side. So initially, this was her imaging from 3 weeks prior to this presentation. So you can see on her sagittal and axial MRI that she has a pathologic fracture at L3 with only a mild retropulsion and pretty well-maintained lumbar lordosis. And then this is the MRI from the day that she presented to the ED. You can see that pathologic fracture is significantly worse. There's significantly more retropulsion, loss of height, with compression of the cauda equina, as well as a focal kyphotic deformity. And then on the far right, you can see the post-contrast scan. This is the CT that she got in the ED for surgical planning. And again, you can see the loss of height of the vertebral body at L3 and the bony retropulsion.
This was a sad case. This lady had been diagnosed with breast cancer a year before and had refused formal treatment and was very hopeful that alternative remedies were going to be effective, and they were not. And by the time she presented with her back issues, she had widely metastatic disease, unfortunately.
So important considerations for this patient, oncologic factors. So she was young, remarkably good functional status for how widespread her Mets were. She was a candidate for further systemic treatment, particularly given the fact that she had foregone traditional treatment initially in her course, and her life expectancy with treatment was greater than 12 months. As far as the stability of this lesion, the fracture is in the mobile spine. Her pain was mechanical. It was a lytic lesion with greater than 50% collapse. We saw that there was a focal deformity at that level. And then the posterior lateral involvement of the tumor was affecting both sides. So that gives her a SIN score of 15, which is in the unstable category. Additional treatment considerations. In this case, we already had a tissue diagnosis from previous biopsies, and we were primarily looking to decompress and stabilize. Her systemic disease, she had further oncologic treatment planned and was actually planned for radiation imminently prior to her worsening back pain in this presentation. So any comments before we move on to the surgical treatment?
Any surgical considerations should include that if you can imagine, she did not want to go through formal chemotherapy for treating her metastatic disease. She was very resistant to considering any surgical intervention as well until this got a whole lot worse, and she could basically couldn't stand or walk.
She actually left AMA from the ED the night she presented and came back the next morning. So.
Yeah, some of these. Sorry, this is Izzy. Some of these young ladies have such a state of denial, and I don't know how to get beyond that. And I've had to deal with a number of patients exactly like this. They just don't want to recognize that they have a problem that we could have easily addressed with a much less invasive procedure and appropriate oncologic care very early on for this group. And it's a problem. I don't know how to get beyond that. If anyone has ideas, please let me know.
You know, just 2 months ago, a patient of mine died with metastatic breast cancer, who was actually a wellness advocate. And she had refused to undergo chemotherapy for her disease, but she agreed to have a thoracic vertebrectomy And I told her we would only do the vertebrectomy and the tumor resection if she would pursue adjuvant radiation treatment, because the disease is going to come back. And she presented, she couldn't walk before surgery, was able to walk and go to rehab afterwards. And she presented 3 months later with recurrent disease, then left the ER, and then came back 2 months later because the disease progressed because she refused any adjuvant treatment, and she passed a matter of sort of weeks after that. So yeah, so very sad. I've certainly seen my share of folks like this as well.
Yeah, it's hard to understand how they can have such responses like that.
So would anybody consider a posterior approach alone here? And does anybody have any experience doing posterior lumbar corpectomies and placing intervertebral expandable cages from a posterior approach in the lumbar region? I was ambitious and hopeful that we could do this all from a posterior approach, and I was wrong for the obvious reasons that, with that degree of vertebral body collapse, the nerve roots were so close to one another, and I just didn't have a robust expandable cage to be able to place from a posterior approach, which is why I took her the next day for a tubular lateral corpectomy at L3. But I'd be curious to see if anybody would consider a posterior vertebrectomy here in the lumbar region, or has anybody attempted these or had success with these in the past?
I have attempted them. I find them to be much more of a struggle. And that's why I resort to what you've done here. This is my go-to for this problem. It's efficient, it's biomechanically stable, and you've addressed all the things that you need to. You've done the decompression. This would be my go-to rather than a all posterior or a posterolateral type of corpectomy.
I think you're really limited when you do it posteriorly because of the nerve roots. I mean, you can do it in the lower thoracic, mid-thoracic region, because you can take a nerve root, roll the spinal cord a little bit, and then get the cage in underneath. Before these expandable cages, people would put in the chest tube and methyl methacrylate with K wires to stabilize, but not as robust anterior construct. I mean, this is a much more elegant and biomechanically stable construct for this solution problem. So I think this is the best solution that you did.
What was her bone quality in L2 and in L4?
Gosh, I'd have to look back at the MRI again. She's a young lady, but she did have disease and widely disseminated disease. But yeah, I think she had, you can see the little lesion at L4. But I think everything else was pretty robust at L2.
Yeah, that's, you see L4. The only other consideration is augmenting the screws. Mm-hmm. And I wouldn't hesitate to augment the screws under these circumstances.
Yeah, I think that's very reasonable.
Okay, so this patient, she did pretty well postoperatively, had no complications. Her exam remained stable, and she actually was able to go home with home health on post-op day 8. At her follow-up visit, her back pain had significantly improved. She rated her about a 3 out of 10. She had full recovery of her motor strength, but she had residual numbness and paresthesias in her left lower extremity. And at this point in her treatment, she is now status post radiation to the spine and ongoing oncologic treatment for her other mets.
So has she finally accepted treatment for her disease, or you think she's still in denial?
No, she did, and she had a brainstem metastases as well that that required radiosurgery, and but she's unfortunately way behind treatment and has undergone radiation treatment in multiple areas of the central nervous system now.
It's a shame. Shame.
The oncologists have been doing such a tremendous job lately of keeping these people going. But I don't think the recognition is there, the public recognition of how well the oncologist can actually treat them now.
I think you're right, Izzy. I think it's a matter of public awareness. They think, oh, they have cancer and they're, that's the end.
Yeah.
And we probably need to do more for, sharing that with the public, how well the oncologists are doing at controlling the spread of tumors.
All right. Well, you guys did a great job. Really unbelievable cases. Great surgery. I know where I'm going. If I have
Good
anything
variety
like
of cases and good discussion. Nicely put
Very
together.
impressive.
Thank you.
Awesome cases, gentlemen. And please send my regards to Jay Khan and make him feel guilty that he wasn't online with us tonight.
We will.
All
All
right.
right. Well, you guys try to stay cool. And thanks again to all the folks at Georgetown.
Great job.
All right.
Great cases.
Take care.
Well done.
Excellent.
All right. Good night, everybody.
Take care.
Bye now.
Thank you.
Don't forget your CMEs.
Thank
Brian.
you.
Hello.
Hi.
Hi.
Thank
Hey,
you.
Brian. Brian, how you
Brian.
doing, buddy?
My goodness. How are
Long
you?
time no see.
I'm well. I'm well. Let me get rid of a few of these things here. There we go. Hey, Rick, it's so good to see you.
I know it's great seeing you, Brian. I thought you were going to do the presentation, but anyway, it's good to
No.
see you. Hope everything's doing well.
Thank
Yeah.
you for, yeah, it's good. It's good. I'm still with Paul. We're back together at Union with McAfee.
We
Yeah,
never
now what
see
is
him
Paul-
anymore.
Yeah, we
He's
don't
like
see him. What's
below
he
the
doing
radar
lately?
screen. What's he up to?
He's still operating 9 cases a week and a madman and doesn't attend very many meetings, just busy in the OR, busy with the residents in the clinic.
So
Is he
kinda-
mainly
he's
doing
kinda like
deformity
not
now?
doing that- He's not doing the academics so much anymore?
Well, technically, he's a professor at Georgetown, like I am, and so we're teaching the residents, and we have a fellowship program, so he's busy with that. Otherwise, not so much. It's MedStar.
Well, tell him hello, please. And
Yeah. And hey, Brian,
Sure.
before you go, what kind of cases is he doing? Is he doing any artificial disc anymore, or that's like?
Yeah, as a matter of fact, he did one on Monday. His first case was a disc, total disc in the neck. He's not doing anything lumbar, but he is doing a fair amount of cervical. And then I would say the lion's share of his cases are just low back degenerative, spondyes, stenosis, and ACDF. I think
Well,
everything
that's
else.
great. Well, we'll give him our best and tell him we miss him. We'd like to see him at a meeting sometime.
Oh,
Or come
yeah.
down to TBI. You too.
I
if
would
you're up for
love
it,
to.
Brian.
I would love
Brian,
to.
we'd love to have you come down, even if you wouldn't mind doing a Zoom grand round for us. Would you be interested?
Be more than happy to. I go 2-3 times a year and do grand rounds at Georgetown. So I'd be delighted to. I'd be delighted to talk
All
about
right.
all the new technologies we're working on, hemostatic agents, coding technologies. It's pretty exciting.
Cool. All right. Well, anyway, great seeing you. You take care and give my best to Paul, okay?
I will. Thank you very much. You guys
All
take
right,
care.
Take care.
Bye-bye.
Hi.
Take care.